This is the lecture for the peripheral venous access and central venous access devices. You will note in D2L there are 3 videos. One covers insertion of a peripheral venous access device. The second one covers accessing a central line, it's primarily a implanted port, and then also PICC care and use of a PICC line. So make sure that you view those. Those are supplements to this content. So when we talk about peripheral venous access devices in particular, we need to think again about what type of therapy is being administered, how long we plan to administer the therapy, what size of catheter we need, of course the vascular assessment. Is this a person that's very dehydrated and very feeble, therefore their veins may be very small, or is it a very a large person with good venous, what appears to be good venous access. And then we also need to think about their preferences and values. Of course, this is just part of patient-centered care as we know it. But patient preferences really get to be involved when you talk about placement, because patients that plan to really do well and be up out of the bed and they really want to make sure that they don't hinder their recovery are going to want to be up and be mobile. So we need to find out for sure from them, where they think the best placement would be. Many people do not like being stuck in the hand because it is very painful. So, always ask them, especially if you feel like the hand may be your only option, ask them, is this okay? And explain to them why you are going to try to use the hand or a painful area to insert the peripheral access device. So when we talk about site selection, we want to consider the placement options. We discussed this just a little bit in one of the other PowerPoints, but your primary options for placement in the arm is the cephalic and basilic veins, the accessory cephalic, upper cephalic, median antebrachial, median basilic, median cubital, and then of course the AC or the antecubital fossa. How do we initiate peripheral venous access and this is primarily going to be looking at short catheters because we do have longer peripheral venous access catheters, but right now we're going to look at the short ones. So when we're starting the IV, we want to, of course, assess the environment. We know that environment can play a huge role on how sterile or how clean we can insert the IV. We want to make sure that we have all of our equipment gathered up. We want to make sure that we have everything that we need and sometimes multiples of our equipment in the room so that if we fail to initiate the IV the first time, we have what we need in the room to try it again. We also want to make sure and wash our hands, of course, and then, of course, choosing the insertion site and then preparing the site for the insertion itself. Okay, so when we're talking about peripheral IV maintenance, a lot of this really relates back to just preparing the site and then, of course, placement, because a lot of the maintenance is really revolved around how well the site can be maintained depending on the location that you put it. So when we talk about peripheral IV maintenance, we're really looking at the patency of the catheter, which means keeping it open so that it can be used for infusion, catheter stabilization, and we talked about that a little bit before. We want that insertion site to be somewhere where we can stabilize the external piece of that catheter very well so that we can prevent it from being dislodged, from infiltration, and of course from extravasation. The dressing itself, anchoring the catheter, assessment, monitoring, and removal of the catheter, and documentation. So when we think about assessment, it's just like with any other nursing process or any other nursing system, we have to assess that peripheral IV frequently, especially when we have infusion going through it, because at any time the IV could go bad and be non-functional, and then we would need to identify that quickly and get that resolved. Number one, because it can damage the tissue in the surrounding area, but also because it's not therapeutic for the patient. The patient's not getting the infusion that they need. So that's assessment, and then of course monitoring, like I said, on an ongoing basis, especially for lines that have been in for 2 or 3 days. And then, of course, removal. We want to get that peripheral IV out as soon as we are finished using it and when it's no longer used, just to prevent any type of complication or infection. And then, of course, documentation. We all know that documentation is a key aspect of what we do as nurses, and it's no different with IV catheters. We need to be documenting the location, what the dressing looks like, how many times it took to get the IV inserted, was it multiple attempts, and then of course that we're flushing, that we're assessing, and that we're maintaining that IV as we're supposed to be. So midline catheters are 3 to 8 inches long. Now your short catheters are about, we'll say about an inch long. The midline catheters, of course, like I said, they're 3 to 8 inches long, so you can see the difference there. They can be single or dual lumen. They are typically placed in the basilic, cephalic, or median cubital veins. These are just larger veins that can tolerate a bigger catheter. The tip resides in the cephalic or basilic vein in the upper arm, at or below the axillary line. Now, this is one of the things that I want you to make sure that you remember. The midline catheter may look like what we call a PICC line, a peripherally inserted central catheter. The difference, however, is that with a PICC line, the tip of the line actually lays in the heart. So with the cephalic and basilic vein, it only goes up toward the upper arm. It's below the axillary line, so it does not cross over the axilla into the cardiac region. So typically midline catheters would be used for duration of therapy for 1 to 4 weeks. Obviously these can be used for a little bit longer period of time, whereas a peripherally inserted short catheter is typically changed about every 3 to 4 days. Or some facilities say replace until, or leave it until it's, non-functional. Also, typically insert midline catheters via sterile technique, and only experienced nurses do this. And to be honest, I've never seen a midline catheter used. It's either an IV, a peripherally inserted short catheter, or a PICC line or central line. So I've never even seen midline catheters utilized. So this is just a picture of what a short and a long catheter look like. You can tell the difference in length. Now a PICC line, this area here is a whole lot longer in a peripherally inserted central line because, again, remember, it goes into the cardiac region. So it's a whole lot longer. Here's a visual representation. So the midline catheter, as you can see, only goes up to the area of the axilla. The tip is circled in red there. Now, when you look at the PICC line, the catheter tip actually extends quite a bit further, and it can actually rest in either the superior vena cava, the inferior vena cava, or in the proximal right atrium. Now, they typically do use the same veins as they do with the midline catheter. It's just that is advanced a lot further than what the midline catheter would be advanced. So now we're going to move on to central venous access device. Central venous access device are what we call central lines. These are also placed into the central venous vasculature. The tip is typically located in the lower third of the superior vena cava or the atriocaval junction. So the tip typically lies in the same place as what the peripherally inserted central catheter is. They are used for rapid administration of solutions. Obviously, it's a larger bore, it's a larger needle, and because it goes into the superior vena cava or the atriocaval junction, that is a large bore vessel, so it can tolerate fluids at a lot more rapid rate. This is considered a procedure that requires informed consent, and that is pretty much a given at any facility. The good thing about the central venous access devices, they can stay in place for weeks to years. Now, typically, if you have a patient that has a central venous access device and they know it's going to be left in place for years, they're going to put a portacath in or an implanted port. But these, I have seen these actually in home health being used for people with IV therapy that were going to be receiving the therapy for several weeks, especially with osteomyelitis. A lot of times those patients are on IV antibiotics for weeks and weeks, so they typically would come home with a central line. As with the PICC line, which we'll talk a little bit about later, the tip is placed or verified by X-ray. Because they have to make sure that the tip is located in the area of the superior vena cava that they want it to be in prior to actually infusing anything through it. And you can see the list of the veins that can actually be used. So these are the type of the central venous access devices. You have non-tunneled central venous access devices, and I'll show you pictures of those here in a minute. Those do have a large bore. They're typically for short-term therapy because the non-tunnel does leave them open for a higher risk of infection, and they're prone to complications. Again, you know, if the part of the catheter is exposed, then you're going to have a risk for infection. Peripherally inserted central catheters, that is the PICC line that we discussed a little earlier. In comparison with those midline catheters, these catheters are a little bit smaller gauge. They are typically inserted percutaneously. You can use them for short or long-term therapy. And they do have less complications than the non-tunnel because the entire PICC line, except for a very small portion, is under the skin, so it's not exposed to the environment. Tunneled CVADs, these are inserted into the central venous structure just like the others. The distal end is pulled through the subcutaneous tissue before exiting the skin, and then cut off before securing in place. Again, these are long-term catheters. There's less complications than the non-tunnel because, again, these are covered by the tissue, therefore limiting the exposure to the environment and decreasing the risk for infection and complications. Implanted port is really the most safe form of central venous access device because the entire port apparatus is in the subcutaneous layer of the skin, so there's no exposure to the external environment that would put it at risk for complications and infection. The only time you're really at risk is when that implanted port is actually accessed. And the way we do that is we use a non-coring needle, also known as a Huber needle, and I think I have a picture of that in here. But these can be single or dual lumen, and you can actually see them underneath the skin, especially on patients who are very emaciated, very slender. Again, fewest complications of all of the central venous access devices. And then we also have implanted infusion ports. These are tunneled catheters that attach to an infusion device. So these are kind of specialty. Don't really see these used a whole lot. Typically we use the implanted port and not the one, you know, that's separate and individual that can be used at different times. But it's kind of the same concept. So here's a non-tunneled versus a PICC. Okay, so you can see the non-tunneled catheter actually is inserted much higher up in the vasculature, as you can see right here. And you can see the tunnel, the catheter itself, there's quite a bit of that exposed. So you can see how that would put the patient at risk for infection. With the PICC line, it enters the body here, and the majority of the catheter, as you can see, is internal. So you only have this very small amount of PICC line that's outside of the body, so that infection risk are less. So this is the tunneled catheter. You can see right here, you can kind of see the catheter up under the skin. So because this is not exposed, this actually helps to prevent infection. Implanted devices, again, this entire apparatus right here would be under the skin. This is as well. So you'd access the center here where the port is, and the port here with that non-coring Huber needle, and that's what you would use to access. So all of this is actually covered by tissue, which really helps to prevent any form of infection. So with site maintenance, of course, we talked a little bit about with peripheral lines, we always want to make sure and look at site assessment, site care, which involves the dressings and chlorhexidine sponges, needleless connectors and access caps, of course, alcohol wipes, stabilizing the catheter. There are different apparatus that we can use for that. Clamps, which is what you can actually clamp the catheter off with when it's not being used, or used, administration sets, and then flushing and locking the catheter, because when a central venous line is used, there's infusion going through it, so that helps to keep it from clotting off. However, if it's not in use, we have to actually close that catheter off at the end and do what we call locking the catheter with a special solution that prevents it from clotting while it's not in use. And then, of course, we can also use any of these lines for venous sampling. Now, I will tell you that you really do need to have an order from the physician to use central venous access devices as a blood draw, because using these devices to obtain blood samples typically shortens the life of that product. So, you know, anytime you draw blood from a PICC line or from a portacath, you risk, you know, the time that that device can be used, and you also cause a risk of the device clotting off. Some of the complications that we can see with central venous lines in particular are occlusion. Of course, this can happen with a peripheral or a centrally inserted line. A fibrin sheath, which is actually just what it says, a fibrin sheath that forms within the catheter itself, which causes the catheter to narrow, and then of course eventually it can occlude the tip of the catheter. Intraluminal occlusion, that's just an occlusion that occurs within the lumen of the catheter itself. A thrombus, or a blood clot in the catheter, or an intraluminal precipitates or lipid buildup. So this is one of the big things with TPN. Anytime you administer TPN, because it is a very viscous, thick, sticky solution, we want to make sure that we really flush that catheter well, because if we don't, and that lipid content within that TPN or the sugar or whatever builds up, it can occlude the catheter pretty quickly. So we always want to make sure and flush those very well. Infection is also a complication, of course. Local site infection, PICC line or peripheral IV insertion site can get infected locally, but you can also have systemic or central line associated bloodstream infections, which are what we call CLABSI. And I have an article in D2L for you to read about that. But because these are invasive, they do enter the body cavities, and they are in the central venous vasculature. Anytime there is an infection, you run the risk of a systemic infection or bloodstream infection. And then, of course, one of the other complications is just damage to the catheter. And this can be done, accidentally by flushing too hard. The tip can be damaged, or even damage to the actual injection site, breaking the tip of the catheter off by screwing the cap on too tight, and then having to break it to get it loose. So there's definitely a risk for catheter damage there.